It's a pleasure to be here. I bring unofficial greetings from your sister organization to the south, Academy Health. I had the privilege of being the founding chair of the board for Academy Health and have had many, many long years of association with it. So it's wonderful to see this gathering today of like-minded and similarly interested scholars and health policy makers. I also want to take a moment to plug our Harkness Fellowship, which I know many of you know about, but I'm sure that there are many potential candidates for that fellowship in this room. It is, of course, an opportunity for Canadians and others from the developed world to spend a year in the United States learning about our very confusing and dysfunctional health system. I think it's great therapy for any of you who are feeling bad about your own health system to come and take a look at ours. It's probably a lot cheaper. We'll also pay your way, so you don't have to lie on a couch and talk about the problems of your healthcare system. I do want to get also now to the topic of the day. We are at a very critical time, both with great opportunity and continuing great difficulty in the healthcare system of the United States. I'm here in part to share what we have been learning in the hopes that you can take advantage of of the lessons of our experience. But I also look forward to hearing from you all about what your lessons of your own experience have been. So, this is what I'm going to talk about. I'm going to talk about the challenges that we are facing in the United States right now, some of the alternatives that we have in front of us, which I suspect are similar in some respects to the alternatives that you're considering, perhaps not with the same level of urgency. Some of the next steps that seem available to us, referencing particularly our path-breaking legislation, the Affordable Care Act, passed a few years ago under President Obama's leadership, and then a report that the Commonwealth Fund Commission on a High-Performance Health System produced this year with its own prescription for how to move forward on the agenda of confronting costs while improving value. And then I will briefly dive into a debate that's ongoing in the United States right now. It may be a very brief debate, but it's a debate about whether we have, through influences not yet fully understood or appreciated, actually seen a slowing down of our healthcare cost increases. So you all, I'm sure, are aware of how broken our healthcare system is. We have extraordinarily high costs. I'll say more about those in just a moment. It includes an enormous amount of wasteful spending. I have been for over 30 years a primary care physician at Massachusetts General Hospital. I've attended as a medical attending on the teaching service of that hospital for several decades, and every day of that experience I saw waste firsthand. And we are very, very good in the United States in wasting healthcare resources. We don't have the quality of care that we would like to have for the amount of money that we spend, and of course there is this continuing embarrassment of the 50-some-odd million uninsured Americans who have not yet, by the way, for the most part, received the benefits of the new law that was passed. So those numbers have gone down a little bit, but not nearly enough. January of this coming year will be a watershed from the standpoint of implementing the Affordable Care Act. Now, the cost of care that prompts the interest of our Commission on Healthcare Costs are illustrated in this comparative slide. The Commonwealth Fund does, as you know, spend a good deal of effort trying to look cross-nationally, and we have concluded that if there was an Olympics in healthcare costs, we would get the top 3 medals. The U.S. is clearly off the charts. You all are kind of in the pack there. I know you're concerned about your own efficiency, but compared to us, you guys look pretty frugal. I want to say a little bit about a conceptual framework for thinking about changing the behavior of health systems. It's very simplistic, but it works for me, especially in trying to think about the choices that we face. And this framework actually is a kind of radical simplification of a framework that was included in a report, very important report by our Institute of Medicine called Crossing the Quality Chasm that was issued about 5 years ago and has had enormous influence on thinking in the United States. But this posits that there is a continual interaction between two types of systems in our healthcare world, what I call microsystems and macrosystems. And it's the interaction between those two systems and their effect on the healthcare world that sets a level of performance. So what are microsystems and macrosystems? Microsystems are where I worked day in and day out as a healthcare provider and clinician. They are physician offices, they are operating rooms, they are emergency departments, they're admitting departments, they are rehabilitation, the units or the floors on rehabilitation hospitals. They are where patients, consumers of care, and their caretakers come together to do the work of the healthcare system. The macrosystems are what is often the subject of conversation in meetings like this. They are the organizational and financial and governing systems of healthcare. They often, in your country, reflect government policy. In our country, they also heavily reflect private decision-making. They include things like government programs and regulations. In our country, health plans and their behavior, large health systems, like some that I will be talking about, accrediting organizations like our Joint Commission, our boards of registration in medicine, and all these entities that set policy that ripples down to the level of practice in all kinds of ways that are often unseen and underappreciated by folks at the front lines, at the sharp end of healthcare. Now, it turns out that we spend a lot of our time, especially health services researchers, studying microsystems. And there's a good reason for that. It's because you can create a sufficient N of microsystems to develop empirical results that are publishable in good journals. That's why we study microsystems. And as a result of those studies, we've generated a fair amount of fairly convincing evidence on what works and what doesn't to improve efficiency and quality of care at the microsystem level. So I've listed a few of the things that have been studied intensively here. One of them that I know very well is computerized decision support through the facilitating influence of computerized provider order entry. There is a vast literature showing beneficial effects of computerized decision support on the quality of provider decisions and on the efficiency of provider decisions. Reminder systems have been shown for decades to improve the rate at which providers recommend preventive services to their patients. It doesn't matter if it's in a computer, it can be a yellow sticky, but if it's a reliable reminder system, it works. Primary care, though we in the United States turn a deaf ear to this, there's a substantial practical experience with primary care that shows its value. And the Toyota production system has been translated now a number of times into effective, beneficial improvements in quality of care in US healthcare systems. I don't know about your experience, if any, here in Canada. Somehow, though, what we know about how to make microsystems better does not get translated into improvements in performance. And this reference to a now decade or so old movie simply captures, I think, the kind of perplexity that those of us who are in the policy world find and often scratch our heads over, that things that work just don't spread. And I think in the United States, at least, there's a reason for that. And that is that our macro systems are not working to promote spread. We've failed to create policies, programs, organizations that make it easy or even necessary to take advantage of what we know based on the literature and on practical experience in healthcare. Now, at this time in the United States, we are up against huge federal deficits that our political leaders have concluded are largely due to out-of-control healthcare costs. Now President Obama, who is a friend of our entitlement programs, our Medicare programs, our Medicaid program, our other healthcare spending program, has more or less said that we don't have a federal deficit problem, we have a healthcare spending problem. And that has certainly captured the imagination of both parties in our political system and teed up a critical choice that we face. We are not anymore at the point or in a situation where we can ignore those healthcare costs. We've been talking about them for ever since I've been involved in this field, which I don't care to discuss in terms of length of time, but it's been a very, very long time. And the fork in the road we face, given the requirement to bring costs under control, is whether we're going to cut benefits, cut payments to providers, cut eligibility for programs. In other words, ration care, at least the care that's available at the current level, or whether we're going to re-engineer healthcare systems to make them work better and make them more efficient and more high-performing. It's hard to argue against improving performance, but the practicality of doing that is the challenge that we face every day. So these are the broad alternatives, just to use a more straightforward schematic. Benefit and price reduction on the one hand, or fundamental delivery system reform on the other. And we are actively now in the United States, at least among policymakers and elite groups, and I can tell you that the US Congress is at this point of discussing this, actively discussing which or what combination of these two devices we want to use. Now, if we are going to make delivery system reform happen, at least in the United States, we must make it much easier to do the right thing. We have macro systems in the form of payment policy, in the form of healthcare organization, that are truly toxic to the efforts to make our system more efficient and higher in quality. So we cannot get from here to there without making it easier to do the right thing. And that, in effect, is what the Affordable Care Act has tried to do. Now, the Affordable Care Act is known where it's known, mostly for its efforts to improve the coverage of our uninsured populations. But it is really two pieces of legislation. One piece about coverage, very complex in its own right, and much discussed in the press. And another piece about health system reform, much less discussed, but equally precedent-setting in terms of its reach and the number of interventions that it proposes to make in macro system behavior in the United States. Now, the Affordable Care Act actually includes a whole set of tools. Our toolbox for change in delivery system is now chock full of new ideas and new directions. And all of these make their appearance in the form of authorities to do demonstrations, pilots, or widespread change within the Affordable Care Act. So there are things like reduced payments for avoidable complications in hospitals, already gone into effect. Value-based purchasing for both hospitals and physicians. Accountable care organizations, which tend to get a lot of play. Whether or not they'll turn out to be the most important thing in the law is not clear, but it's certainly an important new direction. Encouragement of medical homes, bundled payment, a change in the way we reward managed care organizations within the Medicare program, emphasizing quality of care. So one of the themes here is pay for performance on a much larger scale, and prepayment and risk the acceptance of risk on the part of providers at a level that hasn't existed before. Now, the great thing about the Affordable Care Act is that it's got all these new tools. The problem with the Affordable Care Act is that it's got all these new tools. There are so many things flowing out of our federal government in the form of new regulations, new opportunities, new experiments, innovative programs that providers have a choice about whether to participate in, that it is a little bit like being in the middle of a tornado. I think a lot of providers don't know which of these new things to do and how to prioritize them. So we really do need, and this is not something our federal government or even our state governments are comfortable doing given the general hostility toward government in the United States. We need a much more synergistic, organized, comprehensive strategy for improving performance and controlling value. Now, that's not a novel observation, but what's novel is that the tools are present now in legislation to cobble together such a federal strategy. It was with that in mind, in part, that the Commonwealth Fund issued a report in January of this year called Confronting Costs, Stabilizing U.S. Health Spending While Moving Toward a High-Performance Healthcare System. And what it did was it tried to organize these opportunities included in the Affordable Care Act, but also going beyond the Affordable Care Act, to set a direction that, if we followed it, could reduce costs or contain them, but also improve quality and performance. In other words, take the re-engineering route rather than the rationing route. One of the things that we proposed was that the United States, for the first time in its history, say, in effect, 18% of GDP spent on healthcare is enough. We can get by at 18%. And that be adopted as a national target. Now, the mechanism for doing that is not straightforward in the United States because there's no requirement that we set such targets, but states have begun to do that. My own state of Massachusetts has set a target that healthcare growth in both the private and the public sectors in Massachusetts should grow no more than GDP, or gross state product, plus 1%. The other thing that we outlined in the report was that there be three broad directions for reform, none of them surprising, but doing them simultaneously would be very powerful. The first would be to push hard on payment reform to accelerate delivery system change. It's a very important macro system, how we pay for care. It needs to move faster toward risk-based and pay-for-value approaches. Policies to encourage consumer involvement in making sound choices, particularly choices that cause them to get care in high-performing systems. And then a series of other actions that would make markets function better in the US. Now, the target that we identified was not intended to be a sort of absolute break on healthcare spending. It was more set as an aspiration and a form of accountability, one that could be monitored, which we could roll out to state and local levels so that we could identify areas of the system that were more responsible for increasing costs or unable to contain costs. I'm not going to go into this in detail given the time, but we actually had an actuarial research firm, Actuarial Research Corporation, cost out the combination of policies that we put together. And they came back saying that provider payment reforms could save $1.3 trillion over 10 years, better consumer choices about $190 billion, and improving healthcare markets close to $500 billion. In effect, $2 trillion over a 10-year period. That may sound like a lot of money, but in the United States, it's more than a rounding error, but it's not nearly as much as you might think, and I'll show you that in a moment. Now, provider payment reform included incentives for providers to participate in delivery system reforms, including the promotion of accountable care organizations, the promotion of medical homes, the promotion of team-based care, bundled payments for hospitals that were combined payments for inpatient, outpatient, and post-acute care services, and very importantly, finding ways to get private and public payers to use the same incentives and the same directional programs so that providers are not besieged by varying signals about what's valued by payers in terms of quality measures and payment accountability. In terms of consumer choices, there was a heavy emphasis on so-called value-based insurance design, giving consumers incentives to take medications that are proven valuable to the management of chronic illnesses, choosing accountable care organizations and medical homes as the sites of their care, participating and promoting shared decision-making, and accelerating the meaningful use of health information technology, especially to empower consumers with better information. Now, I mentioned that we were going to this set of proposals would save $2 trillion over 10 years, but if you look at the trajectory of healthcare costs, the red line being without these programs, the blue line being with these programs, you can see that it's not like an overwhelming difference in projected payments. It's $5.1 trillion in 2023 instead of $5.5 trillion. It's the difference between those two lines. When you're talking billions and billions of dollars, pretty soon they add up. So the projection would be that we'd be spending 19% of GDP on healthcare in 2023 instead of 21% of GDP on healthcare. It would not bankrupt our doctors or our hospitals. They would still have higher rates of receipt, higher revenues, just not quite as high as they would otherwise have had under the status quo. Now, one of the things that is a persistent challenge for us, not so much for you, but for us, is that given our decentralized, fragmented, ungoverned healthcare system, every payer, and there are thousands of them in the United States, decides how it's going to pay for care. And Medicare and Medicaid, our two major public payers, have their own criteria for making payment decisions. Bringing all those together to create a macro system that moves people and makes it possible to improve performance is an enduring challenge. One of the things that runs across, by the way, is our antitrust laws. So there's a very active debate right now about how and when you can get United Healthcare, Aetna, WellPoint, a local Blue Cross to sit down around the same table and talk about how to pay for care in a consistent way that sends a strong, positive, useful message to local providers. Now, I mentioned that there is a debate going on right now in the United States about whether, in fact, we have won this battle without knowing how. There has been a very dramatic reduction in the rate of increase in healthcare costs in the United States. The red line shows what's happened to healthcare costs annual rate of increase from 2006 to 2011. The blue line talks about what's happened to Medicare, our major healthcare program for the elderly and disabled in the United States in terms of annual rate of per enrollee growth. So you see there's been a big change and a very encouraging change. And if these changes persisted, we would not have the crisis or the extent of the crisis, or at least seemingly the extent of the crisis that has brought us to this point. These are projected rates of growth. The blue and the green line are current projections by our Center for Medicare and Medicaid Services actuary and other projections as compared to the red line, which is what would happen if recent rates of growth were extended out for a period of time. And there's an ongoing debate about whether this slowdown represents the recession, which was, as you all know, one of the most profound in modern history, or something else. That is, whether there are structural changes that have been going on for reasons that aren't entirely clear that are reducing the rate of increase in healthcare costs. And our expert economists are all over the map on this. Some are saying that most of it's due to the recession, people like Victor Fuchs arguing that. Some very noted economists arguing that only about a third of this reduction in rate of growth is due to the recession. We will find out the answer to this, but I would like to argue that in some ways the answer is not entirely relevant. If you look at US healthcare spending And if you imagine that the US healthcare system were placed on an island and floated out into the Pacific, let's say off Vancouver somewhere, you would find that it had the 5th largest GDP of any individual country in the world. After the United States itself at 15 trillion, China, Japan, Germany, Germany's just ahead of us, and then comes the US, the nation of US healthcare. We are twice the GDP of you all in Canada, just on healthcare, every year. And when I learned microeconomics in graduate school, I was taught the concept of opportunity costs. But opportunity costs is a pretty abstract idea. So I asked some of my colleagues at the Commonwealth Fund to reduce the idea of opportunity cost to something a little more tangible. So what we did is we looked at what would have happened, how much money we would have saved if the United States had spent at the same rate as Switzerland, the nearest competitor for our Olympic gold medal of healthcare spending. And we would have saved $15.5 trillion over the last 30 years or so if we had spent at the rate that Switzerland spent. So what could we have done with that? Well, we could have retired our entire national debt and turned it into a $3.6 trillion surplus. We could have sent 175 million students free to a 4-year college. In the United States, education is not free. It is paid for out of pocket, even in state schools increasingly. We could have covered an area the size of our state of South Carolina with solar panels. That would have been enough to power the entire US need for electricity. And we could have bought 4 iPads for every human being on the planet. I'm not sure whether that would be the most useful way, but it would be wonderful for Apple stock, I'm sure. Now, buried in all that spending is a huge amount of waste. This is a wonderful article by Don Berwick and Glenn Hackbarth that looked at the sources of waste in US healthcare, and they are familiar to you: failures of healthcare delivery, failures of care coordination, overtreatment. In our country, administrative complexity, you don't have that problem. But there's a lot that needs to be done to re-engineer care, even if the rate of cost growth has slowed. So that's our challenge. That's one that we are working on in the Commonwealth Fund. We would be delighted to share lessons across the border if there are such lessons. History is not entirely encouraging for the future, but we are at a different point in time than we ever have been before because of the tools that are available in the Affordable Care Act. So it is a time of great experimentation and learning in the United States, and I'm sure we all at the Commonwealth Fund and elsewhere look forward to sharing those lessons with you going forward. Thanks very much for your attention.